Okay, we are continuing to talk about COPD as an umbrella term and the diseases that lie below it. Asthma is one of the ones that we are going to be looking at as well. And this is not talking about typical acute asthma. We're looking at chronic asthma whenever we're talking about it as a disease that falls under the umbrella of COPD. Okay, so we will be talking about acute asthma as well as chronic asthma, but I just wanted to clarify that only the chronic stage of asthma is under COPD. So asthma is an obstructive disease of the lower airway, and it's usually reversible. It's inflammation just of the airway, and it's a hyperresponsiveness to some kind of stimuli, whether it's an allergy or something. It can be acute or chronic. Okay, there's two different types. There's allergic and non-allergic. Allergic is something that is extrinsic, and whenever we use the word extrinsic, we're talking about something that is outside of ourselves. So things like that can be allergens: dust, pollen, pet dander, spores, anything like that. The non-allergic is something that is intrinsic, which means it's something within ourselves that can trigger the asthma. A lot of times it's associated with upper respiratory infections, emotional upsets, sometimes exercise. Some patients experience a mix of the two, and we just really need to be able to understand our patient to understand what's causing it and how to correct it. Acute asthma is increasing airway obstruction caused by a bronchospasm or constriction, inflammation, edema, and production of really thick mucus within the airway. Eventually that mucus can cause plugs within the airway and completely close it off. What you're going to see in patients who are experiencing an asthma attack is shortness of breath, coughing, ineffective coughs with the onset of symptoms, and then as the attack subsides, eventually they're going to be able to cough up whatever mucus has been plugging the airway. After they get to that point where the attack is over, you're going to see a production of some really thick sputum. You're also going to be hearing wheezing and dyspnea, and a lot of that is because it's a bronchoconstriction, where the airway actually starts to close around itself. During an acute episode, it's much harder to breathe. They might experience a sensation of suffocation. They might try to lean forward with their arms at their shoulder height just to stimulate chest expansion and increase the efforts of their diaphragm to open and close the lungs in order to maintain adequate respirations. You also might start noticing that they have prolonged expiration. It takes more effort to remove the trapped air. So short inspiration and then prolonged expiration. Like that. Their skin is usually pretty pale, especially during an attack, and then during a severe attack you're going to start noticing some cyanosis, especially in their lips and their nail beds. Now there is something that is very serious and life-threatening called status asthmaticus, and this is where they have an acute attack that intensifies and continues to progress without getting better. Typically the acute attacks will subside eventually, especially with the assistance of bronchodilators. In status asthmaticus it doesn't, and it's very life-threatening. Eventually they can die from an asthma attack. To diagnose asthma, you want to listen to their inspiratory and expiratory breath sounds. You will be able to hear wheezes in a patient with asthma, especially during an attack. They will have some abnormal pulmonary function tests, and then during the attacks, the ABG is going to show some hypoxemia, and usually their PaCO2 is decreased because of rapid breathing. To treat it, we want to offer some symptomatic relief, especially during an attack. Our long-term goal is just to treat and prevent. If we can determine the cause, then we can avoid whatever the triggers are, but we want to keep some bronchodilators on hand at all times. And also, if it is an allergic reaction, they might end up having to carry epi with them as well. Some medications that we give them, the most common ones are bronchodilators, albuterol, and Atrovent, and those are used in acute treatment of an attack. As a nurse, it's really important to know that you need to stay with your patient in an attack, or if they have asthma and they seem like they might be getting an attack anytime soon, do not leave them in the room by themselves, even to go get somebody. You call someone, you just open the door, you never leave them on their own. Always put them in a sitting position. You want to teach them to rest and increase their fluid intake to thin the secretions as much as possible. Patients with asthma need to understand that asthma is a chronic inflammatory disease. Once you have it, you've always got it. what action and purpose they need to understand also what action and purpose their meds have. If they don't understand why why they have an albuterol inhaler, you need to explain that to them. Exactly how it works, when they use it, why they use it, and then how to avoid things that trigger the attacks. We want to teach them the use of a peak flow meter. You can YouTube or look up any videos, and there's one embedded in your slides if you want to open up your slide presentation on the computer and click on that. Basically, that's just showing the force of expiration when you blow out. It's really effective. And then they need to understand whenever they need to obtain medical assistance as well. If their inhaler is not helping the asthma attack, then they need to call, because it can become very dangerous very quickly. As a nurse, we want to educate them on how to use the peak flow meter, and what is the point of the highest flow that is during a forced expiration. So they'll take the peak flow meter, forced expiration, and whatever the highest point is, that's their ability to expel air. We want to monitor all of our patients, especially during acute attacks, and never ever leave them alone. We want to teach them to avoid triggers like dust or smoking, emotional upset and anxiety, exposure to irritants, cleaning fluids and insecticides and everything too. We also want to teach them to keep their inhalers with them at all times, because an asthma attack can be triggered at any time. So they want to have their inhalers with them in order to treat that as soon as possible. Here's your little mnemonic device for asthma. He's pretty cute, but he's breathing hard. He's got his inhaler. He's got having shortness of breath, some expiratory wheezes, some retractions, tachycardia, signs and symptoms of hypoxia. He's restless. Okay, here's a question. An adult client who has had asthma since early childhood comes to the emergency department in respiratory distress. Which pulse oximetry reading indicates to the nurse that the client has normal tissue oxygenation? Ooh, this is a big one. It's a pulse oximetry reading. Pause it and see if you know. Okay, here's the answer. I hope you got that right. 95 to 100% is what we're looking for with a pulse oximetry reading.